with you. My name is Bob Kruger. I'm the geriatrician from Wilford Hall and BAMC. So I'm kind of a lone wolf. I'm the only geriatrician in the Air Force. Those of you who know Brandy Harris, she's going to be the second one.
Yes.
We have another one. So I know Brandy. She's a delightful lady, and can't wait to get her on board next year. I want to talk to you about falls, but I want to do something a little different. I know people have had death by PowerPoint, where you just stand up and I read my slides, and I want to do a little different approach. I want to kind of talk to you a little bit about falls in older people, because it's very important. And then I'm going to run through my slides real quick, just to make sure that I haven't missed anything, and we can kind of elaborate on other things. If you have any questions at any time, I mean, this is really, really informal. So if you have any questions or observations, or you want to say, hey, that reminds me of a patient we saw, please put your hand up, because I appreciate it very much. I want to make it very personal and very meaningful to you. I brought props along, so we can kind of talk a little bit about what do you do. My mother-in-law's walker, so she's sitting at home right now saying, yeah, I wonder where my walker is. I also brought her cane and her other walker too, so she's pretty immobile right now. So here's my learning objectives. By the end of this talk, you should know that falls are significant. This is a life-threatening problem. This is a horrible thing that happens to old people, and we see it all the time. And a lot of times, it's that one threshold that you can never go back that says, wow, now you've fallen, something else, everything's going to change now. And one of the reasons why I really want to present this is also so we can talk and say, a lot of times it's preventable. Or if we kind of thought a little bit more, we might say, gosh, maybe if we hadn't have done this thing, or maybe if we could have changed something around a little bit more, we could have kept them from falling, we could have kept them in their home a little longer, and we could have helped their quality of life. So falls are a significant life-threatening problem. There's risk factors, and what can we do about it? So we're going to talk a little bit about definition. We're going to talk a little bit about prevalence. We're going to talk a lot about risk factors. I've got some video clips on here that kind of talk a little bit about old people falling. How can we evaluate it? How can we prevent it? And I have some case studies of people you'll say, wow, I treated somebody just like that, or I saw somebody just like that. So let's just talk a little bit more. There's a big difference between falls and syncope. So falls, they were upright, and then they were on the ground. And something happened between up and down. And it's not syncope. It's not like I was up here and then I don't remember, the next thing I remember is being on the ground. I had something happen with my heart. Maybe I went into AFib, rapid ventricular rate, or maybe something else happened. Maybe I had a little seizure. Maybe I had something else that occurred. So it's not because of loss of consciousness, not because of paralysis, not a drop attack, not anything neurologic, not a seizure. But let's talk a little bit more about prevalence, because when you fall, you have a very big chance of falling again. And 30 to 40% of people 65 and older fall each year. I don't call 65 old anymore. I don't know. The closer I get up to those years, I'm kind of thinking, maybe let's move the border a little bit more. But if you're 85, you have a 80% chance of falling each year. If you are in a long-term care facility, so if you're in a nursing home, you have at least a 50%. If you fall, then you have about a 60% chance of falling again. So the risk factors are there. Less than half tell their doctor about it. That's why it's almost like a vital sign. It's almost like, what's your temperature, what's your blood pressure, what's your heart rate? Gee, have you fallen? Because if people fall, we should probably, you know, you're sort of allowed one fall per year. Maybe you were just not lucky. But if you fall 2 times in a year, that's a pattern. And that's something that we need to put that actually even on the problem list, because you have a very big chance of falling again. So, but people don't want to say that they fell. And why is it? Well, they didn't want to tell their doctor because you'd say, well, I was doing something I shouldn't have, and I know that my doctor's going to shake their finger at me. So, you know, sometimes people confess to their doctor that they did something. Sometimes we don't ask. Sometimes it was no injury. Sometimes people think, wow, you know, falling, well, it's just part of getting old, but it's really not. I want to take a second, though, and just talk about, why do old people fall? Why do old people fall?
Well, the deficits that they have, visual deficits or cognitive, just in that to me it's really frustrating. You can go in there and tell them, now make sure you put the brakes on, but you know, they forget.
Yep.
So I think the biggest, well, I guess it depends on what part. If they're cognitively impaired, that's a different group, but also I think just physical deficits that they have.
Sure, and we can talk about normal aging and we can talk about pathologic aging. One of the things you brought up was a great point. I love rollators. You can get these, the Air Force, the military will buy them for you, the Medicare will buy them for you. If you go out and you buy these, you can get a really good one on Amazon.com for about $100. If you go to Champs Medical, you probably pay about $200 or up for about the same thing. But this is a great thing to have. I never request scooters, because once, as you know, once people get into a scooter, they never get up. They never continue walking. But this is the greatest invention known to man, a rollator. It has handbrakes, as you know, and to set the brakes, you push down. Pretty good. Big RV wheels, 5-inch wheels. Great. Not like the little tiny ones, little 3-inch wheels that you used to have in the past. This is something you can take out to the parking lot, and you can go all over the place with it. Some of them have baskets on it. Not this one. $35 more. Some older people don't like to spend $35. But a little basket underneath is great, because you can put your purse, you can put other things in it. You can sit on it. So how do you sit on it? Well, there's a specific way, and as you said, sometimes older people don't get sequencing very well. You have to set the brakes, turn around, sit down. Not turn around, sit down, set the brakes. So if you have a hard time sequencing, this thing can scoot out from under you. Another thing, very, very important thing that we see, and I know some of you have seen this as well, somebody say, wow, this is the greatest thing because I can use it not only as a walker, but as a wheelchair. So I can have someone sit in there if they get tired, we can pull the brakes off, and I can wheel them all around, which is a great idea until you come to a little change in the pavement, or from one concrete slab to another, where there's a little bit of a change, because they're sitting up here. Where's their center of gravity? Kind of right here. Boom. What's the next thing to hit? The head. So if you ever see anybody doing something like that, kind of tap them on the shoulder and say, you know, probably not a great idea. If they need to be in a wheelchair, have them in a wheelchair or a transport chair, which is lower center of gravity, safe, and much more equipped for that kind of behavior. So, but rollators, wonderful. Kind of getting back a little bit more to falls in older people, let's just talk a little bit about why other things. How about some normal aging things that would cause people to fall? Can anybody think about anything normal aging that might help someone fall?
Arthritis.
Arthritis, yep. Very common in older people. What else? Neuropathies, yes. Very, very common. I can't feel my feet, something like that. So if we kind of think about balance, what are the three organs that cause you to balance? Well, it's your eyes, it's your vestibular apparatus inside your ears, your inner ear, and it's your feet pressure sensors for proprioception. So, and you also have to have a brain that integrates all three of those. So think about what happens in older people very commonly. If your eyes, macular degeneration, cataracts, almost any kind of eye something, that takes one of three out. Vestibular apparatus, if you have benign paroxysmal positional vertigo, that might take that out as well. If you have peripheral neuropathy, if you have diabetes, that might take this out as well. So you can almost wonder, how could people not fall if you're old? So, very important. There's another thing called sarcopenia. And I know everybody's heard about osteopenia. You know, we know osteoporosis, normal bone mineral density, osteoporosis, way thin bones. But in the middle, in that gray area, is osteopenia, thinned bones. So is that you're normal, you're osteopenic, then you're osteoporotic? Can happen. Sometimes people get to osteopenia and just stay there for the rest of their life. So something we kind of watch and monitor. But also there's the same thing happens with muscles as well, sarcopenia. And you can see it in a normal older person. Take a look at their hands. They lose a lot of their distal musculature. So, and then things happen, so they have to actually move for balance and for correction on up to the more proximal muscles, the bigger muscles that really weren't equipped for that kind of behavior. So, for example, me standing here, my center of gravity is within my body, kind of right about here, maybe about a third of the way from here. Also, though, I'm standing just using the little muscles of my feet. It's a very efficient way of standing here because I'm not really doing anything big. I'm just doing, my body's doing a little correction using these little tiny muscles. I could stand here for hours and it really wouldn't do anything. Think about older people though, if you've lost some of your muscles, so you've lost the little distal muscles down here, now you have to back up a little bit more and you're using the larger muscles here, not really equipped for fine movements. Here's a common stance for an older person. Their feet a little bit more spread, a little more stable, maybe a little bit flexed at the knees, and maybe a little bent over here, almost like a football stance, but kind of think. So this is commonly how people with sarcopenia stand, something like this. They really got to work on this because they don't have the little muscles of their feet to help correct them. So we're going to see some video clips in a little bit of some older people with sarcopenia. How do they correct? Well, here's a preview. How do you correct? Well, you're going to use something like this. You have to put your arms way out, almost like a tightrope walker. You'll have to use the big muscles of your legs and your back. something like this. So very, very difficult for them to regain position once they've almost fallen. So let's go ahead back to the slides a little bit, and we can kind of talk a little bit more about what's up. So every 29 minutes, an older adult dies from a fall. Not necessarily a fall itself, but maybe a fall or a complication of a fall. Greater than 2 million ER visits for falls each year and $28 billion annually. Well, you can really say, I think that's conservative. Because if you kind of think an old person who might be living independently paying taxes, now they are maybe in a nursing home, maybe they're in long-term care, so there's a lot of expense to them themselves. Clinical presentation, 41% minor injury, so a laceration or a bruise or a soft tissue injury or a non-injury. Boy, I got through that when I fell onto the couch. You know, great. What are some bad things that can happen though from a fall? You can hit your head, yeah. Fractures, big time. What are some of the fractures that we see? Hip fractures. Wrist fractures, stroke. What's some other fractures that we see?
Skull.
We see, right, we see some proximal humerus fractures. We see pelvic fractures. What's the worst fracture you can possibly have? So there's some kind of good fractures and bad fractures. Probably the worst, one of the worst fractures is like a pelvic fracture, because it's non-weight bearing. So what do we tell people if they have pelvic fractures? Well, we gotta have you laying in bed, or we can't really go on in and do surgery on that. We can't correct it, so it has to heal on its own. That's a bad fracture, because when we're going to take maybe a person who was upright doing stuff, and we're going to put them to bed, and they're going to be in a lot of pain. A pubic ramus fracture is a horrible fracture. Everyone here is sitting on their pubic ramus, so you can't really sit. You can't really stand for a long length of time. If you lay down, well, you might be on your pubic ramus, but that might be a comfortable place to be. So, and we all always know when you put an older person to bed, then they get more deconditioned, increasing risk for fracture. Do they have to go to the bathroom on a, maybe they need a catheter? What happens when you have a catheter in an older person?
Infection.
Yep, you get a urinary tract infection, you get skin breakdown. I have lots of pain, so I need to take narcotics, which is going to cause me to have delirium. So you can almost see the downward spiral on that. A different fracture, I guess there are probably no good fractures, but a less worse fracture might be a hip fracture. Because you can take them to surgery, you can pin it, and they're up walking around maybe the next day. So that might be a little better. You know, proximal humerus fracture, well, I mean, that's not a great fracture because we don't really go on in, we sling it. A wrist fracture, not a great fracture, but, you know, we're going to put a cast on it. Vertebral fracture, horrible fracture because they're painful every time you move around. You know, you're going to have pain from that. So these are some horrible things. 6% major injury, lacerations, fractures. I heard over here head trauma, so subdural hematoma, subarachnoid hemorrhage, so something like that. There's not a lot of place for blood to go once it gets into your skull. Squeezes your brain out on the bottom. That's a horrible, horrible way. Yes, ma'am.
But you know, one of the things that happens though when you have those subdural hematomas, you know, because of the space, you know, so you may not see what happens. It may be a couple of days or a week before you realize that they got a problem.
Yep. I've been fooled by subdural hematoma. You're exactly right. Someone comes in with dementia, Or, wow, you know, over the last 3 weeks they've really gotten bad. Something's going on. Must be a urinary tract infection? Nope. Must be pneumonia? Nope. Must be something else? Nope. And then somebody finally says, well, let's do a head CT scan. Wow, look at that. All that blood that's there. Head or facial trauma. Long line falls are horrible. I fell and I didn't get up. So that's really bad because they were laying on the floor for a long time. So rhabdomyolysis, one more thing that we see. So complications. So falls, bad. It's the leading cause of death from injury in persons over 65. So real bad. And also lose your independence. Now where are you going to be? You can't be at home anymore. This is very interesting entity, fear of falling. I don't want to fall. I remember that fall. It was a horrible fall, so I'm just going to park myself down in a chair and not get up. What does that bring up? More deconditioning, more risk for falls. So, some real badness from that. So the trajectory of decline is something very common, something very tragic. So we talked about sarcopenia, the thinning of your muscles. Now, just because your muscles thin out doesn't mean that you have to be weaker, because even thin muscles respond very well to physical therapy. So we're going to talk about in a few minutes, after we talk about prevention, what do we do about it? How do we get folks back on the road to recovery? And let's work on those muscles and get them stronger. And it really, really works. So balance factors, we also talked about that with my eyes, my vestibular apparatus, my proprioception, figuring out where I am in space. So a lot of times, older people fall because of something. So they're a setup, but then the situation occurs and they fall. For example, middle of the night, I have macular degeneration or cataracts. I can't really see, but I need to go to the bathroom. So on their way to the bathroom, they forgot that somebody put that ottoman right there in the center of the room. So they walked and they hit it and they fell. Maybe if we had had a night light, they would have seen that. So setup plus situation equals fall. Let's look a little bit more at what happens when old people fall. Just to tell you something about these video clips, I got these off of YouTube. Some people feel that it's really funny to see old people fall. It's not. So I'm trying to bring some positive out of a negative here. So we're going to use this as a teaching moment. So let's take a look at what happens with this guy. Okay, so he fell. Look how he's on the way down. Take a look at that. So how does he fall? Well, actually, what's the setup? He's an old guy. Somebody said, gee, let's take Grandpa to the coast. So Grandpa may have some visual disturbances. Maybe he can't see that the water is going like this, and maybe it makes him a little dizzy when the water is going like that. Maybe there's really bright sunlight, so if he has cataracts, what happens when people with cataracts in bright sunlight? You know, it's like white out, so he can't really see where he's going to go. So, and he's using those proximal muscles to, he's kind of going like this, trying to grab any way he can, because he doesn't have the compensatory factors. So that's kind of painful. However, he fell into nice soft water. That's the goodness. Let's look at number 2, video clip number 2. Gee, it's a nice day. Let's go out and jump rope. Oh, Grandma says, when I was little, I was a championship jump roper. That looks like fun. Oops. There we go. Jung, jing, jing, and bong. Oh, let's try that again here. Whoops. Back up. So, you know, back when I was, so if you think, back when you're littler, you have the little muscles, you can jump up and down because they can also help you, you can recruit the big muscles and the little muscles. She got 2 jumps before she went down. Here's the third one. So this is called error in judgment. Gee, back in the 1950s when hula hoops came out, I was a championship hula hooper. Okay, kids, let me show you how it's done.
Oh my gosh.
I know. Maybe somebody should have said to Grandma before, hey, let's... Whoa. She fell on something. I don't know what it is, but... Yeah. But take a look here. Are these her shoes that she left behind? So that's another kind of environmental factor that you may want to think about. You know, it's great to send... Well, maybe it's not her. Oh, she took over. But, you know, the SAS shoes are the most ugly shoes known to man, but they're the most wonderful shoes. You buy an SAS shoes, you never have to buy another pair. Because they're forever. So, now, I'm a simple man, and I like to talk about, let's talk about mnemonics. So I got through medical school trying to figure out mnemonics. However, I could never remember what they stood for. I remembered my mnemonic. So this is a mnemonic called MEOW. And these are risk factors that kind of help you remember what some of the risk factors for falling are. MEOW. And one of the things you might want to think about is the cat lady. Anybody ever seen cat ladies? You know, little old ladies who love cats. So, this is a little old lady who loves her cats, and she has, whoops, uh-oh, Mark, help. Oh, what did I do? Oh, that's perfect. Thank you. Okay. Oh, here's our cat lady. She has 135 cats. It's feeding time. Here, cats. Woo. So, now, do you think she's going to trip over her cats? Probably. You know, if you have 135 cats. But meow. So, M, risk factors. Medical. Acute medical, chronic medical. Medications, memory, many previous falls. What kind of acute medical issues might cause an older person to fall?
Syncope.
Syncope, very good. Or urinary tract infection, maybe delirium, something like that. Chronic medical conditions, I heard arthritis over here, which is a big thing.
Medication.
Or
side effects.
Yep, very much. Medications, what kind of medications can cause old people to fall? Sleepers can do that. Antipsychotics. Blood pressure medications, diuretics, big time. Interestingly, I learned something on this when I was preparing for this. Narcotics, I would have thought narcotics would be right up there number 1. There's no evidence that says narcotics can do that, so it would seem that it probably could. Memory, many previous falls. So this is very, very important. And risk factors. So heart failure, Parkinson's disease, that kind of says, yep. Osteoarthritis, carotid disease, maybe thyroid disease. We'll talk about thyroid this afternoon. And dementia. So very, very important. M, risk factors. E, let's talk about some E risk factors. Anybody think about any E risk factors? Environment, very big time. Whoops, there's some more of these. So anticholinergics, ditropan can cause that, something like Haldol, Ativan. So E, environmental, eyes and ears, and ethanol. Okay, so alcohol use can cause that. O, orthostatic hypotension. So if you stand up, so if you're dehydrated, you can get orthostatic. Ouch! Arthritis or gait changes or older age. The older you are, the higher your risk for fall. So O can cause that. W, women and men have the same risk factors. However, when women fall, they get injured more often. Probably because of osteoporosis. But weakness, so normal aging, deconditioning. So evaluation, how do you evaluate this? Well, you ask. Ask with every visit. Have you fallen? Have you fallen recently? How's your gait? History and physical, and maybe labs and images, maybe a head CAT scan sometimes is important on that. Here's another type of test specifically to focus on falls. The time get up and go. Anybody ever done a get up and go test? It's an easy test to do because you tell someone, put your arms like this, now stand up without pushing off, walk across the room, turn around, and sit back down. So if they can do that in 14 seconds, that's pretty good. So kind of think about that. So when they stand up, how are your muscle strength? How's your balance? When they walk across the room, do they have a wide base gait like this? Can they turn around? Or are they someone who has Parkinson's disease? When they get over here, they have a hard time. Let's say I got to move around like this and go on over and sit back down. So that can kind of give you a little bit of an idea on how they work. Performance-oriented mobility assessment, the POMA. This is a 9-point scale of a lot of different tests that we can do, or the functional reach. So put a mark on the wall here. If they can reach out 6 inches, that's pretty good. But if they start to go out to 6 inches and then they start to fall, that's a negative functional reach. So how do we prevent it? Well, we treat it. We treat the medical issue, treat any kind of risk factors that we can think about. Maybe we need to change their medicines. Maybe we need to get them off of some of them, maybe the diuretics, maybe the Ativan, sleepers. A lot of times people say, I really want a sleeper, so maybe they might, you know, you have a lot of choices. Maybe we could give them Ambien, or maybe we could say, here, take a little melatonin. That might help you. Melatonin, I love melatonin. 5 to 15 milligrams of melatonin at bedtime really can help people and doesn't have those adverse side effects. Sometimes home safety evaluation, maybe we need to get home health on in. Maybe we need to get into physical therapy. I've never had Medicare turn down or TRICARE turn down my request for outpatient physical therapy for someone because it really helps and they get stronger. And maybe a mobility device, give something like that to help them. So I want to talk about some case studies. I've got 3 big case studies before we break for lunch. Kind of think a little bit more about risk factors. What risk factors out of the MEOW, M-E-O-W, might you see in this? What happened? So what's the setup? What's the something occurred and then they fell? And what interventions should we use, or how should we have, what can we do about this? Here's the first one. This is MJ, active and healthy, 82-year-old lady, lives independently at home. Great. She has mild congestive heart failure and takes furosemide, takes Lasix, a diuretic. She also takes ditropan for urinary incontinence. Yesterday afternoon on a hot San Antonio summer day, she was out mowing her lawn, middle of the day. EMS brought her to the emergency room.
Oh my goodness.
Ever see anybody like this? Yeah. Kind of hard to hide that.
Raccoon eyes.
So raccoon eyes, right? Raccoon eyes. So what do you think? What were some things that set her up for that?
Diuretic.
Diuretics.
The diuretics. So she was already
The
fluid
ditropan.
down here.
The ditropan.
She's a woman.
Right. She did Tropan,
Dehydration.
anticholinergic medication, error in judgment, summer day. So it's a hot summer day in San Antonio, 105.
Yeah.
It's not 80, it's a cool fall day.
And probably no hat either.
That's right. That's right, no cat. So that's, and I'm sorry, no hat, no hat. That's perfect. You're exactly right. So, so case study number 2. Mr. E.D. is a diabetic, 77-year-old man with moderate dementia who lives in a senior apartment. Osteoarthritis, so ouch, takes hydrocodone and amitriptyline for pain. He also takes risperidone at bedtime for hallucinations and clonazepam to help him sleep. We really want him to sleep. While ambulating to the bathroom overnight, he fell and fractured his hip. And this is what it looked like. Ouch. That's bad, bad. Let's think about some of the risk factors here. So he's diabetic. What happens when you're diabetic?
Neuropathy.
Yeah, neuropathy. Yep. Moderate dementia. So the M, the mental. Osteoarthritis. Okay. So he probably takes some medicine for osteoarthritis as well. Hydrocodone, amitriptyline for pain.
So his hip could have broken, then he fell.
That's true. Oh, that's true. Yep, he sure could have. He could have. Maybe he twisted, broke something, and then fell. Very common.
But also, too, him being a diabetic, he may have had
Low blood sugar.
in addition
Could have been.
to the other stuff.
Great point. Yep. Especially in the middle of the night. You know, maybe he took his insulin at bedtime and then wanted to get up and ambulate. So fell, fractured his hip.
Risk factors.
Here's our last one. Mrs. LM is an 85-year-old lady with macular degeneration, lives alone at home. Her husband died 6 months ago. She has no family close by. So she is a isolated elder.
Oh,
2 to 3 bourbon drinks nightly. Maybe she lost track. Hydrocodone twice daily for arthritis and zolpidem for sleep. Her housekeeper found her the next morning lying beside her bed, unable to stand up. That's what she looks like. So this is a long lie. So this is someone who is in bad shape. She probably, if she survives, probably will never, she'll have to be not in an assisted living, probably nursing home. What do you see? Alcohol.
Sleeping.
Visual problems.
Visual, yep. Lots of stuff. Lots and lots and lots of risk factors. No social, nobody to say, well, you know, Mom, you need to stop drinking or cut it down.
Well, if they were talking to her, they probably, we wouldn't have to do the alcohol.
Probably, yep. Yep, maybe she's lonely. So that's it. So, whoops. So we understand that falls are a significant life-threatening problem. Risk factors, lots and lots of them, and we need to just take a look at them, ask questions, and take care of them. Thank you so much for your participation and your attention. Yes.
2 comments. I didn't see laxative mentioned in the medication, but a person, a senior on a valve prep is at extreme risk, I think, and that's a
I completely agree. So the question was, if someone's on a laxative, on a bowel prep, what happens with that is, you're right, because that's instant dehydration. And then what do you do with a bowel prep? You have to get up, walk, and get back. Get up, walk. You're dehydrated, so you're going to get up and you're walking. You're going to wobble.
And the other thing is that when a senior falls and breaks their hip, their life changes. It also changes the life of the caregiver. That is significant.
Yep. Great point. Wonderful, wonderful point. It does, anybody who loves them, anybody who's taking care of them is definitely affected. So I'm going to let you go for lunch, turn it over to you guys, but I'll be up here, so if any questions, and then at 1 o'clock we'll talk about thyroid.